Good afternoon and welcome to the COVID-19 Preparedness webinar series by the Max Institute of Healthcare Management at the Indian School of Business. I am Soumya Shashidhara, the Associate Director at the Institute and the host of the series. We are pleased to organize this webinar in association with Alumni Engagement at ISB and the Healthcare Alumni Special Interest Group. I would like to thank Hima Bindu, Senior Associate Director, Alumni Engagement, and her team for this partnership. In our earlier webinars, we have talked about ICU preparedness, role of home care, teleconsulting, healthcare innovation, and maintaining healthcare continuity during the unprecedented lockdown conditions. Since we are looking at a staggered exit of lockdown, the time has come to discuss lockdown exit strategy for healthcare organizations. I'm delighted to welcome Professor Sarang Deo, Professor of Operations Management and Executive Director of Max Institute of Healthcare Management at the Indian School of Business, to the webinar. As discussants, we have Dr. Satish Reddy, Managing Director of Aster Prime Hospital, Hyderabad, alumnus of ISB's Advanced Management Program for Healthcare, class of 2018, and Vibhav Tewari, Chief Operating Officer of Portea Medical. I will begin the discussion by asking a few questions to Sarang, and after which I will hand over the session to Professor Deo. Professor Deo, you are currently working with various state governments on COVID-19 related issues, and you're also a member of the COVID-19 data analysis group of the government of Punjab. Can you tell us about your experience of working with the government and what does it inform us of what to expect in the near future?
Sure. Thanks, Soumya, for the introduction and for the question. So as you said, there's several work streams that the Max Institute is currently undertaking on COVID-related topics. Some of that is as part of my work with the Punjab government and some others more independently. One of the things that we are closely looking at and doing some modeling work is on the fundamental issue of projecting where the pandemic is going in terms of number of cases. As we all know, in India, the testing rate has been very low compared to other countries, and it has increased, but not increased as much as many people would like. So making sense of the reported cases becomes difficult, and hence projecting in the future becomes difficult. So we are building mathematical models to understand how to incorporate this testing rate to get a more accurate projection on what the actual number of cases may be in the community and not just the reported cases. And once we have that handled, then we can say, hey, what would be the impact of various policy measures of removing lockdown, more intensified testing if you remove lockdown, how should removal of lockdown be informed by serological studies? How frequently would you have to do serological studies, etc., etc. So that's one piece of work. We are also doing more operational work in trying to understand what are the different bottlenecks and constraints for testing. Everyone seems to talk about lab capacity and machines availability. What we are finding, perhaps surprisingly or not, is that even the steps of sample collection and transportation present a major challenge. And so we've done some analytic work around evaluating various different sample collection and transportation models. I guess not unlike the work that a lot of home healthcare providers already do, and I may have some thoughts on that later. But we are finding that the current models used in many districts cannot scale, and they often become a bottleneck even if there is testing capacity in those states available. So those are sort of the main work streams currently.
So just to set a background to the discussion of lockdown exit of healthcare organizations itself, can you share possible scenarios we can anticipate post-lockdown, and what is some of your modeling work telling us in this direction? And after this, I would like to hand over the session to you. So over to you, Professor Sarang.
Sure. I mean, given exactly as I said, the uncertainty around where our epidemic is exactly today, and some of us are a bit concerned about the increasing number of cases in the past few days in India. Is that because the testing has ramped up recently, or is that because whatever partial removal of restrictions is causing a surge in the cases? So based on those, we've built a few scenarios. I think in some of the scenarios we are seeing that there is likely to be a second peak several months down the line. Again, this differs from state to state. So when we run the model for Telangana versus when we run the model for Punjab, we get very different answers. Because of the way these states have adopted their testing strategies and the demographics of those states, etc., mixing patterns. I don't want to alarm people, and make them sort of leave the desk right now and rush somewhere. But I think it is fairly well accepted and established that this is not a one-time phenomenon, that we sort of remove the lockdown and forget about COVID entirely. The testing strategy would have to evolve, but it would have to continue. And this is testing of individuals, but also measuring prevalence at the population, at the community level on a regular basis, and that informing which communities to open up, which to still keep under containment zones. ICMR has come up with very good guidelines, but in our experience of working with state governments, we see a severe constraining capacity at the district level where a lot of these things have to be actually implemented. And so we are trying to work with one of the districts to see how can those guidelines be translated into an operational plan. So think about that as an exit strategy for a district, not for individual organizations.
So now we'll come to the specific topic at hand about, kind of how to set priorities. First, to understand what's happening now, and then to set priorities, or rather a plan for various healthcare organizations to exit out of the partial shutdown of healthcare services. So I now hand over the session to you to talk to Dr. Satish and Vibhav. Over to you.
Thank you, Soumya, and welcome, Vaibhav and Satish. Thank you for taking time in this, difficult situation. I know both of you are very busy given, the organizations that you represent and the situation we are in. And also thank you to all the participants, alums, as well as other participants, again, for engaging with this event and showing interest in knowing more about what's going on. It is, I think, just to give a brief primer before we move, what we are going to focus on today is not so much the public health response, which we can talk at length and everyone has a view. I want to make it clear that today's discussion will focus around individual healthcare organizations on what their strategies are coming out of a lockdown situation. It is, I think, apparent to everyone in this discussion, in this webinar, that healthcare is unlike other sectors. So if I were to discuss e-commerce, the strategy of coming out of the lockdown, or manufacturing sector, there would be a different set of considerations. As Soumya alluded to, healthcare is not even under full lockdown scenario because they are at the forefront. So they are working, albeit in different mode. And so some of the things that we discuss here would be unique to this sector, but important. I would also say that our discussion will be mostly around healthcare delivery organizations. Again, in the interest of time, we can't cover everything. So there will be unique issues around possibly pharmaceuticals, diagnostics, device manufacturers, which are within the healthcare realm, but we won't be able to cover them in our discussion, maybe for another time. So with that primer, I want to first start by asking both Satish first and then Vaibhav about first their assessment of the current situation. Just before we get into the exit strategy, what have been the main effects on their organization of the lockdown? And what has been their assessment of the past few weeks? So challenges and what have they sort of made changes, one or two changes to deal with the lockdown situation? Just a minute or two each. So Satish first and then Vaibhav.
Thank you, Sarang, and thank you, everybody. Just getting on straight into the topic. Last 40 days, we've had, we've been under lockdown and we have stopped all elective procedures. We have stopped outpatient departments, and we've been accepting only emergencies in the last 40 days. And even though we had been preparing since late February or early March and regarding to segregating patients at the entry point, implementing screening of patients, and already hospitals are supposed to have, let's say, hand hygiene, and the compliance rate is about 85 to 90%. Now you need to bring it up to 100% and make sure that it is being done on a more frequent basis. And in the meanwhile, we also had, in Telangana specifically, all the COVID patients are supposed to be treated in government setups. And in spite of us accepting only emergencies, we've had a couple of patients who had been tested elsewhere and who had been COVID negative. And we also know that there are some amount of false negatives in this testing. And then they turned out to be positive when we were in the hospital, when they were in our hospital. And then eventually we had to put a large number of our healthcare employees under quarantine, and that affected the day-to-day operations, because 30 people going off work at the same time is a huge hit for the employees. So then we also had to create a scenario where we will receive COVID patients. We had a green corridor and a red corridor for COVID and non-COVID, in anticipation that we may be asked to step in to start treating COVID patients. So let me put it, as of now, we have not been asked to do that. And our the patient occupancy has fallen by about 90%. So this is where we are, even though we can discuss the changes we have made to treat the scenario and what we will do post in subsequent questions.
Thank you, Satish, for that introductory comment. Very helpful. Vaibhav, moving to you, given that you represent a home healthcare organization, I'm pretty sure that the challenges you faced are different from a hospital setup. So could you talk about what those effects are, and are they differential across the service portfolio that you provide in any way? Vaibhav, you may be on mute.
Yeah, sorry. So thanks, Sarang, and thanks everyone for being here. I think from our perspective, the context is a little different, given that we are present across the country. So when the whole COVID crisis happened and the lockdown started, each state, depending on their preparedness and readiness, behaved very differently or reacted very differently on how to implement the lockdown. And in the first few days, there's a lot of administrative work to be done along with different state governments in terms of our people getting passes and vehicles and everything to go to patient homes. In our case, the service provider, the caregiver, and the clinicians also have to travel from their homes to the patient homes and provide service to them. So we had to basically work with governments, each state and each city, to basically make sure that we get passes and other necessary approvals for people to travel. And of course, work with patients, assess each of the patient's situation and see what falls into critical versus non-critical requirements and which services we continue. So I think for first 1 week or so for us, a lot of administrative work. We learned a lot about how each city and state functions, who are the police personnel, and how do you go and work with each one of them, how do you get passes, and so on and so forth. And also working with patients on specific requirements. So certain patients who are in the critical needs and needed the clinician and the nurses and the caregivers to be with them, we moved them to stay with the patient on a 24-hour basis. Those services happening for a shift. But many of the patients graciously accepted that let the caregiver and nurse stay with them so that they don't have to travel. So those kind of adjustments we did. And then, of course, what is coming into primary care, like a physiotherapy and other services, which we looked at how we can move that to more video-based. So patients who needed physiotherapy, we said, look, it's very difficult for physiotherapists to travel to your location every day or alternate day, given the current scenario. We moved them to basically saying as much video consults I could do as much possible, apart from teleconsult for doctors as well. So that's how we tackled the first week. And of course, each city settled into its own rhythm. And then from then, it has been with some semblance of normalcy in the new normal, as we say. And that has been the functioning for last 6 weeks or so.
Thank you, Vaibhav. I mean, this is very useful to get these views from both of you, because the reason we chose two different organizations is the way the pandemic has affected these sectors can be very different. What I heard from Satish is essential and non-essential to some extent in a hospital can be mapped, if not perfectly, to elective surgeries, emergency surgeries. In a new business model, that may be difficult to do. One has to start from scratch and say, how do I start even defining what is essential, what is non-essential? Also, I guess even governments have figured out a way to deal with hospitals and work with hospitals, but with new business models, as we constantly see, regulations and guidelines have to be modified. They're also, learning on the fly, and so that may lead to some friction. But I'm happy to hear that things have quote unquote settled down for now, and you can get back to the new sort of abnormal normal. With that, I think I want to then move to how we are thinking about the post-lockdown world, and we all sort of intuitively understand that post-lockdown world is not going to be the same as pre-lockdown world. What is going to be different, of course, it's everyone's guess at this moment. But as we say in medicine, do no harm first. So I want to start with the safety measures. As a patient, as a caregiver, my first concern is, even if the lockdown is lifted, is it okay to go back to a doctor's office or a hospital? And this may not be the same concern as if should I go for groceries or should I go for some other essential services. So people need some sort of assurance that plans are in place for safety of patients. So I would like to hear again from both of you, maybe Satish first as a previous question. But also safety measures for healthcare workers, because that translates into safety for patients eventually. And if possible, could you talk about specific plans, sort of business processes put in place to guarantee safety? That would be very instructive. Thanks. Satish?
I think this is a big topic actually, because it involves a lot of changes which have happened in the last 40-45 days. Yeah, once lockdown is lifted, I think I would start with one word of caution that we need to actually ring fence our own vulnerable people who are around us. That is the people who are above 65 and with comorbid conditions. They should not be allowed to move around freely, and we should restrict their access to the other people who are moving out into the society also to a great deal. And I would always suggest a cautious restart, because the hospital, the people who are coming to the hospital, the doctors as well as the employees are living in that environment where there is a chance of a higher viral load. There are patients who, the reason people are coming to the hospital is because they are with an ailment, isn't it? And coming to the preparedness, to just to give a word of caution to all the people who are visiting hospitals, is that we have, I would explain that into multiple buckets. Let's say there are employer responsibilities and employee responsibilities. Employees are expected to maintain proper hygiene, social distancing, wear a mask, and follow all, even transportation of nurses. Let's say, for example, from their hostel to the hospital. Instead of making one trip, now we have to make 3 trips because we have to have only one person sitting in every seat. So that thinking has already gone into these things. We have a separate entry and exit for the employees. All of them are screened again when they're coming into the hospital. We have done away with biometrics in terms of their attendance. Initially, we had become manual again. Now we have moved to facial recognition. And coming to them working in the hospital, they have to all are being given proper PPEs, and they have all been trained in the last 40 days. We have taken this time to prepare them for in terms of handling these kind of patients. And today, because of the kind of testing we are and the environment we are in, we have to treat almost all patients as possibly having an exposure to COVID and maybe harboring the virus. So we have to treat all of them in the same bucket, because we are not allowed to test these patients when they come into the hospital. And then you have to look at things like simple things like going into the canteen, giving them graded breaks so that all of them are not sitting in the canteen at the same time. And in the operating theater, for example, we have installed showers where they will have to actually have a shower after every procedure, so that their exposure to these viral loads will become less. So these are some of the things which we have asked the employees to do. Now, coming to the employer responsibility, again, I would subclassify them into, let's say, infrastructural changes which we have to make. We have had to make one entry, one exit for the patients again, and we have to start screening the patients at the entry, giving them wider berth when they're sitting and waiting for the doctors. Disinfecting and cleaning the high touch point zones. The bathrooms, let's say, were being cleaned every 4 hours before, would have to be cleaned every 2 hours now. The doctors' rooms have to be cleaned, including the ceiling on a weekly basis with hypochlorite solutions. And then some amount of changes in terms of the door handles. Try to install some automatic door handles, maybe elbow pushing and those kind of things. And then operational modifications, I've already said, in terms of screening and things like that. Another quick point about infrastructural changes is, when we are talking of private, our individual organization, for example, we had the operating theaters which were built with positive pressure ventilation, and that's what is the standard across the world so far. Now we are talking about negative pressure ventilation for the hospitals, which is a big ask in terms of getting a modification done. And there are some people who are saying that if you already have 25 air changes per hour in the operating theater, that is okay. So these are things which are still fluid. We may have to do things as we go forward. Right. And then some of the other interventions are the other most important thing was human resource management in terms of rotating the people who are in the forefront in terms of ER, the intensivists and the anesthetists. We need to rotate them on a regular basis. And then if one of them is infected, then we have to actually find, not infected, exposed, let us say. We have to find somebody else to get in and to step into their shoes and take over the responsibilities. That has been a major problem in terms of the limited number of human resources available to us. And this is not the right time to even recruit if you want to recruit. Yes. So broadly, I think these are some of the changes which we have made. I can go into specifics if required.
No, this is again very helpful, and thanks for the granularity that you provide, Satish. I'm struck by the fact that you have to really get into the nitty-gritty of what are all the possibilities where breach can happen. As we often say in these situations, we are only as strong as our weakest link. So I'm already imagining a process flow of staff coming in and staff leaving, and I want to be able to visualize every small instance where there may be a breach in safety and they may be exposed to the virus. It's not just washing hands before and after touching the patient, but right from the moment they enter the premises, their lunch break. So this is really instructive and helpful. And I wonder, just a quick follow-up question or a thought, and we can follow it up later. It seems that all of this is well and good during the lockdown, because you mentioned 90% reduction in volume, so which means there is time to do all this and be careful. And now one wonders, as the lockdown is lifted and as the patient volume increases, but we can't let go of these safety measures, there is going to be a real trade-off, and it's not a good trade-off, but a trade-off between how careful you want to be in each of these activities. It takes time, and at the same time, there may be patient load, and you also don't want patients to wait for a long time. You want to serve them well. So I'll just park that thought for now, that this challenge may become more pronounced after the lockdown as people start to come in. You want to serve them fast, but to serve them fast, you still want to reserve some capacity of your staff to do their cleaning, disinfection, all of those processes. So that's an operational challenge. But Vaibhav, moving to you, and what struck me is with Satish's description is, in a facility-based healthcare delivery, although challenging, a lot of things are under control, right? So in operations, we talk about centralized operations and distributed operations. And one of the benefits of centralized operation is good oversight, quality assurance, quality control. And I'm wondering, what have you had to improvise in terms of safety of your healthcare workers and patients / customers when you can't see them, when you don't have them on premise? And again, if you can respond to what will have to change as the volume of services grows, yet these safety standards have to be maintained.
So from our perspective, the thing with change, and of course the change started right when the lockdown also started. So in our case, it's not that our occupancy equivalent is not down, will be down probably like 20% or so. So because only the non-essential medical services stopped, everything has continued at patient home. So we have continued to run at fairly large numbers even during lockdown. For us, the most important thing which happened is that we look at each of our clinicians and have an assessment for them before they start a duty. So now earlier assessment, what you were doing and now what you are doing will change a little bit, where you do a full-fledged medical assessment as well. You do basically a teleconsulting session with them, with your own employee before they go for the patient visit, actually, for the first time if they are doing that. And if they are going every day and have to do every day a teleconsult, we have the infrastructure with doctors who are basically checking these people. If they are traveling to and fro from patient place, that are we doing the vitals check basically remotely for them? That's something which we implement. Second thing, what we are implementing started a couple of weeks back also is that every patient whom we are starting new, and especially who's getting discharged from the hospital and then we are taking them to support at home, we are basically asking the complete history of them as well as their family members. It becomes very critical given that it's very contagious. So in our earlier assessment of when we start a patient visit and duties, a lot of things around medical, which didn't include these kind of things, but it includes a lot more details around COVID. In fact, a lot of patients, we also ask if when they're getting admitted in hospitals, they are doing the COVID tests now. We are asking for those reports as well because it's very infectious for our people to go for. And wherever patient asks for that, we also get the test done for our employees now. Earlier it was not possible, but I'm also getting a report of our employees, basically our clinicians getting COVID testing done and saying that report is there depending on the doctor prescription. And that report is available for the patient not to catch infection from our people potentially actually. So those kind of things, which are the new things which have implemented compared to what we are doing earlier. From an on-premise perspective and the employee-employer perspective, what I think Satish mentioned is correct. Actually, we are doing exactly the same thing. Your sanitizers, masks. We also made sure that we are distributing to all our employees who are traveling to patient place. They carry it as a kit. So earlier, some of their kits will contain like a BP monitor and things like that. Now their kit contains each of these things. Also, you have to make sure that supplies are available with them on an ongoing basis. We basically interact with our clinicians a lot more in the current scenario than what we did in the past. A lot more training actually for them has happened, which refreshers and things like that, because getting them up the curve and continue to make sure that they are retaining that knowledge and maintaining that precaution is very important. So the multiple ways and the multiple times we have to do that has changed significantly in this post-COVID scenario.
Thanks, Vaibhav. And I'll quickly ask a follow-up question. As you said, your volumes have not come down that much, yet we are doing more things, or staff has to do more things, more checks and balances. How have they taken this on? Because there's always pressure time pressure, right, to do things, and they're moving around, etc. So what has been their response and feedback? Does it take up their time? Have they figured out efficient ways of doing this?
So people have figured out efficient ways of doing that. Especially they have to start some of these things when they reach the patient home, right? So once I come in, I have to basically make sure I sanitize my hands and whatever else I have to do before I start the treatment for the patient. So that's something which is implemented where we have done the training for patient also, saying that for you to be safe, what to see in the clinician, or clinician to be safe, what you need to do before the treatment starts. So each of that training has become very critical, and we do that. I think one very interesting and positive point across the board in the field, we have seen tremendous response from our people to handle this crisis. I think a lot of people are seeing this as an opportunity to serve patients actually. So, and I was talking about administrative thing, and which is of course not related to this question, but the way our field teams responded to handle each of those things to make sure duties don't suffer. Because fact is, as a clinician, you see this patient every day, and you know that this patient will not be comfortable if I'm not there today. And as a clinician, I have to reach this place one way or other. So the ownership that clinicians have taken, our admin staff has taken in the field, has been really exemplary actually. And that's where the caregiving has come out, and the real sense of caregiving, what we always talk about, saying that empathy and caregiving has to be part of healthcare. Our teams demonstrated that. So a lot of these things became essential for them, and they've adopted that quite well.
Very good to hear that. Thanks, Vaibhav. Satish, coming to you then, sort of moving beyond immediate safety, now slowly services have to resume. And you mentioned that a lot of non-essential or elective surgeries had to be cancelled / postponed. Could you talk about now what is the plan of bringing them back on board? And specifically, if you could talk about, there are multiple specialties in a hospital such as yours. Doctors from different specialties may have their own preferences. You can't start all specialties at the same time. So how are you balancing all these different factors? And do you have a sort of a staggered plan of when will which procedures, specialties open?
Hi,
Sorry?
And you're
Yeah, I think so. Sorry, there was another voice there. So, but please go ahead.
I think the most important thing in this is, see, whatever we have been doing in this COVID time actually has not been learning a new skill. Most of these skills are already there with our healthcare workers in terms of taking care of, it's just making a habit of it and putting a procedure in place. So what I would suggest is that I don't think we should hit the ground running. We should not take all comers and then say, I'll do everything for you. For example, if you take, I agree with what you said in terms of different specialties having their own requirements, but to keep it in general, I would say we should admit patients who require, let's say, a short stay or a daycare procedure, 24 hours to daycare procedure, and the procedure also should be a short procedure. You should not be operating for 7 hours, 8 hours at a stretch. So start with those, pick up the real emergencies. Let's say in orthopedic perspective, you start doing you've already been doing your hip fractures and those kind of things. So pick up the real emergencies, the relative emergencies, which are short stay, which can be sent back home very quickly. And these patients you start doing, and then it gives an idea for the organization to understand where they stand. It's good to talk about theory and then putting it into practice. So as we go forward, we will understand, use this as a dry run for the bigger number of patients to come in and go on for the next couple of weeks, 2 or 3 weeks, you will understand what is happening to the pandemic around you also, because that's still something which is very fluid. So after which you can start ramping up your procedures slowly.
Right. So that's a very... Go ahead.
Sorry. To the specific departments, I would say there are some departments where we call aerosol generating procedures happen, like ENT, endoscopy, orthopedics in terms of the drills and the power instruments we use. These are the departments I would say go a little slow. And let's say a general medicine department or other departments where you can actually protect yourself with PPE and you're not creating aerosol generating procedures, those are the departments you could maybe ramp up a little quicker. So these are this is the way I would do it. But end of the day, we should not be compromising on the patient care or the standard of care, isn't it? That is something paramount which we have to maintain. So I think going slow is better.
Right. No, that's very helpful, Satish. So what I'm hearing is 2 or 3 dimensions. So one is just the clinical dimension. The nature of the procedure itself could generate risk at high, medium, low level. The second is, the operational side of the procedure, meaning how much crowding does it generate for the hospital, because lesser is better, and how much time direct contact does it generate for healthcare workers and patients. Of course, there are financial considerations, and I'll come to those later, because they may also have to be weaved in, even if not prioritized in deciding what to resume when. But a quick follow-up question to that, Satish, is do you have, or do you think hospitals should have some sort of a well-defined phasing, meaning, hey, in the first few weeks, I do not want my peak load of patients or people in the hospital to be more than certain number, and slowly I will relax that, as you said, as I learn. So is there sort of a number in people's mind that suddenly I don't want 1,000 people in the hospital first day I open my doors?
I don't think I don't have a specific number in my mind. I've not thought in terms of statistics there, but I would. Clinical perspective, which is the and even if you look at the last 4, I think sort of looked at least. So if there is a real emergency, urgent help, I am putting a number, a slab on top. I would take necessary precaution and do the needful. At the same time, we should get clinicians not to risks and to relatively can be put off for another.
Satish, losing your audio.
I also can you hear me now?
Now, yes. Could you summarize your response, because it's possible other people lost your audio too? Sorry.
What I was saying was, I've not actually thought of in terms of a number, a slab on, to say this is the number of patients I would take in. We were thinking more in terms of a clinical response, where the real emergencies and the patients who require urgent care need to be taken care of, whatever may be the constraints we have. Because on the last 40 days already, I think a lot of non-COVID patients have not gotten the kind of care which they deserve.
Right. Very good. No, thanks, Satish. That's helpful to know. If I can move to Vaibhav. Vaibhav, you talked about some positive elements of lockdown and what we've learned. Could you possibly give examples where some of these changes that were forced, so to speak, on us are now emerging as opportunities, and there is now plan to develop long-term competencies around these, maybe offer new services? It would be good to know if there are such examples.
Sure. So from our perspective, from a home care perspective, I think the opportunity of the COVID, in that sense of post-COVID, is quite enormous, because home care or healthcare outside the hospital has come into focus in a very, very big way. Actually, last 40 days, if you see. So, our premise always is for tertiary care, you go to hospital, for everything else will come home. And in today's time, home care has come right in the center for patients, for us, and for everyone. Even from government perspective, if you see any of the government directives when these are coming out, are talking about caregivers, they are allowed, home nursing is allowed. So home care is getting accepted as a critical part of healthcare, is become very prominent now. In fact, even for many state governments have allowed now for patients to be treated at home who are early stage of COVID, actually. So in the first instance, everyone was supposed to go to hospital. Now government is saying, and many state governments have said that you can treat patients at home. In fact, we launched that offering. We are working with many state governments now to treat these patients at home, leveraging teleconsulting and other technologies. And that's something which is a tremendous development from what it was earlier. From the other side, we see a lot of opportunity in terms of people having a lot more focus on primary care, a lot more focus on preventive care. Before this, all of us think we are immortals, right? Something goes wrong like this, happens to my neighbor and not to me. But you know that people who have hypertension, people are diabetic, chronic disease, have a lot more propensity to catch this disease, right? So people's willingness to take care of their health is changing in a big way, actually. And that we believe, like our diabetes management solution, we are seeing tremendous demand from patients for that. I mean, the whole counseling piece, people are saying, okay, can I take this counseling package and you take care of my diabetes? Because I know that if I continue with this infection or something else will come and hit me. Same thing on elder care. Elderly people, the way elder care was happening in this country before or worldwide before is changing. I mean, you see half of US deaths or half of France deaths, I think have happened in old age homes, actually, and which are not as equipped as they should be. So now elder care, can you do for patients at home? Again, something tremendous need, which we see as a big opportunity. The most important thing which has come out of it, for vulnerable segment like people who are cancer patients and all, for them to go to hospitals for even complex procedures from a home care perspective, like chemo at home, like chemotherapy and all, people are saying, can we do at home? So we have a lot of pharmaceutical companies which we are working with and saying, can I do chemotherapy at home? Can I do a lot more onco procedures at home? We have started at least 20 new patients in last 15 days to do chemotherapy at home with multiple sessions lined up. So these are kind of things which, of course, we always talked about as a home care provider and home care pioneer, but the ecosystem is asking for it a lot more today than what happened. So the way we look at it, outside the hospital care, home care will be right in the center of healthcare going forward, and primary care, preventive care, complex procedures also what can be done at home, elder care will become very, very important and big opportunities for everyone.
Thank you, Vaibhav, for that response. Satish, to you, I have similar question, but maybe I'll tweak it a little bit. I know, first of all, that Aster has very recently launched a home healthcare program or a vertical, and so maybe you sort of are in a good position on that one. but teleconsultations, right? This comes up several times. Many of us who are on the webinar may have experienced as patients teleconsultation for the first time. But I wanted to hear from you the perspective of providers, because we tend to hear that doctors and providers are reluctant to adopt technology. What has been their response during this crisis around adoption of technology? And second, how are organization, maybe your organizations, trying to tap into that temporary adoption and make it more systemized? And a corollary of that is, can that be used to mitigate some of the adverse financial shocks that this crisis may have put on hospitals? So slightly longish question, but I wanted to segue from the previous question to this. Satish, are you still with us?
Satish has messaged he's off again. Dinkar, can you look into it, please? Sarang, why don't you proceed with another question to Vibhav?
I think we can proceed. In fact, what I would suggest is, in the interest of time, to open up for Q&A from the participants, if that's okay, Soumya. And as Satish comes online, I will bring back this question on finances. A lot of participants have already asked about the financial thing, but let's go to participants now.
Absolutely, Sarang. I think a lot of pre-questions have been weaved into the conversation, but I think there's a lot of questions around how do we deal with cost optimization, and sort of how do we work on the cash flow, given that it's very short, given that things will be very tight in the near future. So I would want to take that from a business perspective for any.
Vibhav, do you want to take that on? Have there been initiatives on cost optimization given the situation?
Sure. So of course, given that, as I said, around 20% services were down in the first month and a half. And given that any business, I mean, of course, we have to look at the cost pressures. We have to look at the overall business economics one more round, and continuously do that. And this situation has basically created a scenario in which 3 to 6 months where it will take for things to become normal again. So from our perspective, we continuously look at what additional services we can offer to patients, what additional needs we can take care of different segments. So that takes care of inflow of the patients for us. And at the back end, how do we run and support the costs? For example, in our case, work from home for all the office staff, actually, because each of the cities have offices also, and we have looked at how we can make that not only this time thing, but on an ongoing basis also, can I have more work from home? Because we believe that, I mean, I myself may be a little bit more old school in that sense, didn't believe in work from home so much earlier, but 40 days we have worked on and off from home, and we believe it works. So we are looking at, can we create those kind of situations? Can we have people a little bit more variabilized salaries? People have voluntarily have come and taken salary cuts for temporary basis, because people believe that employees believe that this is the current scenario. Everybody has to contribute to how do we run the business. So those kind of things we are doing, both from a revenue generation perspective, what other opportunities we can tap, and the current services, how best to optimize the cost under each head, whether it is clinician cost, admin cost, other overhead, sales and marketing. Those kind of things have been looked at line by line from a business planning perspective. Other thing which we have done from our business perspective, given that we have a large customer base, we have served over close to 1.5 million patients so far. We are also reaching out to our old patients from a sales perspective, marketing, saying what other home care needs they may have in the newer scenario. And seeing, because in that case, I mean, just from a business perspective, your customer acquisition costs lower, right? They're already an existing customer. So can you engage with them better and take care of their needs, because there will be additional needs in this time. And while the situation becomes normal from a new patient walk-in perspective, what else we can do to engage with the old patients better? Other thing which happened in our case is that there's certain business lines like in equipment. We also do medical equipment renting and sale to our patients. And we saw last month and a half, there's tremendous demand for medical equipment, whether it's for ventilators or oxygen concentrators, BiPAP. People are seeing tremendous demand for that, both for the current need as well as from a safety perspective, preparatory need perspective. And that particular segment has picked up well. So we look at all the business lines, what we can do differently, look at the current patients, what we can do, look at each of the cost line items and see what we can reduce, how we can involve employees more into it. I think the thing is that there's a lot of cost optimization and rationalization is a lot about working with employees as stakeholders and not driving it top down, because scenario everybody knows. I mean, all of us know this one lifetime situation. I mean, none of us have seen a situation like this when oil has been sub-zero. I mean, we won't even think of that, right? And those kind of scenarios, I mean, I was reading somewhere Wimbledon got postponed for the first time after World War II. So, I mean, situations like this you have never seen. So in this, everybody has to come in the front and say what they can do to sustain the momentum, given that we are in an industry which has to be in the front. See, look at in this scenario, healthcare and police are the two services which are right there serving people. So we have to do that while maintaining that business maintains. So from my perspective, each business will have their own cost line items which they have to work on, but involving employees, involving stakeholders a lot more actively becomes very critical. While we figure out, like as you were asking Satish about teleconsulting, what we can look at from a newer opportunity perspective. A lot of hospitals are offering teleconsulting as an additional thing now. And those kind of things, so we look at new business opportunities, look at the cost items, leverage all the stakeholders to take ownership. Those are things which we need to look at systematically to weather this storm actually in the next 3 months.
Yeah, thanks, Vaibhav. What seems insightful to me is, I mean, there's a maxim which says no cost is fixed cost. So one has to sort of think, how can I convert my fixed costs into variable costs and then involve employees to rationalize those, but also not to stop at cost optimization. It seems that there may be ways to enhance value addition to the patients. Sort of also look at top line enhancement during this difficult time. It seems counterintuitive, but there seem possibilities of doing so, not only get obsessed with cost reduction. So thanks for those insights. I see Satish is back now. Satish,
I'm back.
Excellent, excellent. So if
you hear me?
Yeah, of course. Yeah, so very good. So let's quickly go back to the question. We were anyway discussing it. Teleconsultation, providers' adoption of this new modality, and how can we sort of tap into that newfound maybe acceptance and systemize it for large organization, converting that into a revenue stream in this difficult financial time. So that's my long question, but all interrelated.
Yeah, teleconsultation, I think we have to adapt it now. Before, what was happening in the urban people is that because of the availability and the proximity of the doctor, the adaptability was better in the rural areas when compared to the urban population. But now what is happening is, some of the specialties, for example, would definitely want one physical consult. But so I mean, some of them can be done, even the first consultation can be on tele. But once the patient is acquainted with you and is happy with your diagnosis and treatment, and there is a connection which is developed, I think it's best you can shift many review consultations to start with, at least onto teleconsultation. Post-operative consultations, and let's say, for example, you have treated a fractured femur, and you need to see the guy again maybe in 6 weeks time when when you want to get another fresh X-ray done. But in the meanwhile, for whatever doubts he has, for whatever guidance he requires, teleconsultation would be an ideal way. There is no point in a patient coming to the cardiologist to say, okay, this is my EKG, it is looking normal, this is the medication which I'm taking, okay, well and good, continue the same thing. I think these are some things which we can definitely shift to the teleconsultation method. We will increase even the hospitals are in the process of increasing our reach to these patients by doing home consults, by getting these investigations done at home. And EKG can be done at home very easily by providing them with medications at home. So a home care you will see a lot of more home care happening from the hospital side also.
Very good. Just a quick follow-up question on this teleconsultation thing. In health systems which are payer-driven, it requires a regulation change for the payer to say, okay, we will pay for teleconsultation in addition to face-to-face consultation. And then the patient takes the service depending on how comfortable they are, but payment is not an issue. In a system like ours, where there's a lot of out-of-pocket expenditure, how do we also overcome this challenge of making patients realize the value of it to pay for teleconsultation? What's your thought on that?
See, already in the last 40 days, let's say from our hospital perspective, we have already launched a teleconsultation app. And we are doing a fair number of consultations on telephone.
Oh, very good. Thanks, Satish. Soumya, going back to you, are there questions from the participants that we can address?
Sure. So I think the next point comes to the fact that since there is going to be a slightly enhanced cost of delivery of care, what is the industry thinking about pricing strategies? I think that will be a very helpful indication to see how much of it is going to be transferred, what can be absorbed, and how are the margins going to work out in this scenario.
Yeah, Satish, could you take on that question? I mean, there's even us as educational institutions struggle with this issue of should we tinker with price in this situation, or because that has long-term consequences. Prices are sticky one way. So what is the thought?
There is a business and there is a moral angle to both these things. When you look at the kind of changes which you need to make, let us say, for example, infrastructural changes, they are capital intensive. At the same time, there are some low-cost solutions. See, when you're looking at private healthcare, I'm just going out of the the purview of not discussing only about our hospital.
Yeah, of
talking
course.
of in general the healthcare, with private healthcare, and 80% of the private healthcare is the smaller hospitals, isn't it? So we can actually, there is plenty of information available from WHO in terms of airborne infections. Mm-hmm. We could adopt some of these changes into our existing practices. The difference I would suspect, as of now, I can be wrong, is that the rate of infection is much higher in COVID, but end of the day, it is an airborne infection. The simple example being in an outpatient department, there is evidence which says that if you have a window which is about 1:40 when compared to the floor area, the chance of you having an infection comes down by 95% because of the ventilation which is happening. Now, this is something which everybody can adopt. You don't have to put an AHU there. So this is a way of trying to mitigate, reduce the capital cost, in terms of trying to adapt to the COVID scenario. If you're looking at the PPE cost, there is no way you can actually, you have to protect yourself, and you protect yourself, and also by protecting yourself, you are preventing this transmission to another patient also. There, the cost of the PPE, I think, has to be borne by somebody. So depending on the margins which you are having and the cost at which you are acquiring, you may sometimes elect to pass it on, or you may not elect to pass it on. In this present pandemic, as a policy in our hospital, we had taken a decision that till this acute emergency lockdown phase is over, we will absorb the cost of the PPEs.
Nice. Okay, thanks. We're moving towards the end time, and there are so many good questions actually coming out from the participants. I wish we had time to address all of those around teleconsultation, new models of delivery, patient engagement. How do we continue to engage patients even though they may not be coming to hospitals and clinics? But towards the end of this discussion, I want some sort of blue sky thinking as well. In many other sectors, we talk about the preponderance of unorganized players in the sector and how this crisis may have affected them irreversibly. A lot of businesses going bankrupt or going out of business, etc. And we know in healthcare, this is unusual, but for India, a lot of healthcare is also unorganized. And I'm not talking about quacks here, or I'm not talking about informal providers. But a lot of formal healthcare provision is also in an unorganized manner. Could both of you, Vaibhav and Satish, based on your experience and what you're seeing, take a guess, conjecture? I know nobody can be right here, but conjecture on, the industry structure likely change after this? Would you see consolidation? Would you see, some small organizations finding it hard to sustain business, or that actually there is much more resilience and so nothing will change? I want you to take a sort of hunch.
From our perspective, the way I look at it, I believe healthcare will be like the front and center industry if I can call it industry going forward. Of course, the focus on making sure that we are prepared to take care of any perception around safety and what you were discussing in the beginning also becomes a lot more critical. So the way we audit our services, whether for home care or for hospitals and everything, becomes a lot more important. So opportunity is going to be tremendous in healthcare. Of course, everybody has to ramp up to match those requirements. Some will do, some will not. So there will be surely some consolidation. We see that, but this is a big landscape going forward. I would believe that in a good or in a bad way, this is like something which has opened up need to focus on healthcare a lot more, private as well as public actually. So under a lot more scrutiny, and in that sense, a lot more opportunity as well.
Satish, so increased cost of, let's say, maintaining all these safety measures and compliance, plus consumers, let's say, concern of going to smaller players. Do you think those would be important factors and smaller hospitals will find it hard?
I think the smaller hospitals will find it hard. The resilience is, one of the factors for the resilience is how long this is going to last. If this is going to last much longer, see, for let us say a district hospital which is operating on very thin margins, and they are dependent on, let's say, this government scheme patients, which majority of them are operating on, then on an average, we had calculated that you would require about 15 PPE kits per patient if you are looking at somebody, taking into consideration somebody who is just symptomatic and who requires some treatment, and somebody who has been on the ventilator. So taking on an average, you require anywhere around 15 PPE kits. Now, on an average, if you take the costing to be about 1,000, and even in future, if it comes down to 500, you're talking about 7,500 rupees per patient, an increase in cost of based on PPE alone. So these kind of margins are not available to many of the hospitals in the districts to be able to absorb. So I think this is going to be a landmark event, the actual black swan event in our for our healthcare industry, which is going to push it either this way or that way in terms of consolidation among the big players, or the public health getting much better, so that many people are able to move to the public health also.
Well, thanks, Satish. I mean, in the closing from me, at least, I would say that there is also a role for entities like NHA and PMJ to play. In fact, we've been working with them on some of the related issues, because I think there will be a stronger movement from out of pocket to sort of payer-driven systems after this. At least that's my conjecture. But I'll stop here. Again, I apologize to all the participants whose questions we've not been able to address, although we had an inkling of what you would like to ask, and so we've tried to model the conversation along those lines. But over to Soumya now. Thanks.
Thank you so much, Satish and Vibhav, for your candid responses. But thank you so much, Sarang, for doing what you do in our healthcare program, pushing people to think in a very systematic way, in bringing in systems and connecting the dots across all the three elements of payer, provider, and and the government entity, which is the regulator. So if the participants have found this conversation interesting, I'm sure they will also find the program that we run at ISB relevant to them. The Advanced Management Program for Healthcare is a modular program for senior professionals from the healthcare industry. Just to simplify what we do at the program, it helps develop business acumen. So we are looking at functional leaders who are very senior in their organization, in the industry, who want to come and kind of wear the additional hat of a business person, keeping in mind the dynamics of the healthcare industry, understand a larger healthcare ecosystem. I think that becomes much more relevant during the pandemic now that the government participation or the lacuna in the public health, what is the implication for the private sector, and how all these models are going to emerge and change in the near future, to understand the challenges and the opportunities. Definitely to try and see the trends and to see what are the innovations that can come out of it. And at a very personal and individual level, leadership and collaborative competencies, which are very critical to lead. May it be a steady state organization or a situation in a crisis, we need leaders and skills, and that is what we do at the program. So for this round, we are almost done with the admissions. We'll be starting our classes sometime in the August, inshallah, hopefully on time. But we do have the last round of applications we are taking until tomorrow. So if anybody is interested, please go ahead and then look at our web page, www.isb.edu/AMPH, or write in to us at amph@isb.edu. We would love to be in touch and see how we can participate in your journey of developing into taking your skills to the next level in your mid-career progression. Coming to the next set of my announcement on webinars, the next Max Institute of Healthcare Management webinar is with the Equitable Health Access Consortium. Professor D.V.R. Sheshadri of ISB will be talking to Dr. G.N. Rao on managing human capital and ensuring organizational sustainability. We will be putting up the details of the link on our LinkedIn page. So please catch us there. It is Healthcare at ISB on LinkedIn. And the next webinar by the Healthcare Special Interest Group of the Alumni Engagement is going to be led by Ritesh Dogra, a PGP class of 2009 alum. He's going to be talking to Neelakanta Gollakunta, President and CEO of GE Healthcare and Managing Director of Wipro GE. It is going to be an engaging conversation, something that is at the focus at this point. Thank you so much for everybody for the participation. Thank you for all the alumni who are on the call. You are our pillar of support. Hopefully at the end of the pandemic, we are going to, which is hopefully going to be soon, we are going to be come out resilient, stronger, and with a very different view of what is going to happen in the future. So stay safe, stay connected with us, and look forward to seeing you at our next webinar. Bye-bye for now.